We're going to start off this session from first starting with the heart. I mentioned to you that we are so excited to be funding the expansion of the Action Network. So our first speaker now, this session is going to be Chet Villa. Chet and his colleagues are the ones that are leading the effort in the Action Network. Chet is from Cincinnati Children's Hospital and is amazing in what he's going to do to make sure this heart is built to last. So with that, I'll give you Chet Villa. Thank
you. So first, I think for most of these talks, everyone says thank you at the end. I think we need to say thank you at the beginning and probably take a second to acknowledge everything that PPMD and Pat has done. I think thank you. I think that support is not helpful just for what we're doing now, but also creating a pipeline for young people who are doing cardiology or thinking about cardiology to say this is a field where you can make a huge difference, right? And that's important to build a stable of cardiologists throughout the country so that we can deliver effective cardiac care, not just when you're in Cincinnati, not just when you're in Columbus, not just when you're in Phoenix, but everywhere. Here you see my disclosures. And so when I think about the fundamentals of delivering effective cardiac care right now, I think about 5 big things. One, how we're going to screen for cardiac function and fibrosis. It turns out, especially from a Duchenne and for all dystrophinopathies, if you're not looking, you have no idea what's going on. You have to do that effectively and efficiently. 2, from a rhythm perspective, as you heard from Dr. Barth, for those of you that were in the cardiac session there, we are just starting to appreciate how that fibrosis starts to show itself from an electrophysiologic perspective, from the electrical signals in the heart, and how that's going to make a difference over the long term, both in Duchenne and especially in Becker and in carriers. This is a really important thing as we move along across the life spectrum. And then 3, what I'm going to talk about the most here, which is medications, day-to-day medications. How can we make a difference right now? A lot of the funding that PPMD is putting forward is going to be talking about novel therapies and how we're going to monitor people over the next 2 to 3 years. But what we're going to talk about today is what we can do right now, because there are things that we can do right now. And that's just as much about learning from each other. That is, 1, learning from other cardiologists, so non-DMD cardiomyopathy, what we can learn and how we can do that more effectively, and 2, from neurologists. What we are starting to appreciate is the heart is a muscle, right? We've always known that, but it turns out some of the things that we have seen from things like imaging DMD and from biopsy studies, we're starting to see some of those changes now from a cardiac perspective, and that has to shape how we go about trying to deliver effective therapies, and we have to talk about it that way. When we talk about how to treat neuromuscular disease and skeletal muscle disease, you don't say, okay, well, I'm going to wait until you lose ambulation and then I'm going to start steroids, right? There's nobody in this room that would do that. From a cardiac perspective, that is what we have done for 3 decades, right? When you look at the synergy data, only 50 to 60% of those boys with cardiomyopathy were on any cardiac medication, any, at all. And when you look at multi-center data to see for people who passed away from cardiomyopathy, we know they died of heart disease. A total of about 15 to 20% of them aren't even on an ACE inhibitor. That's the very basic therapy that we should have everyone on way earlier. And they weren't even on that. Don't even get me started about lower down, because the numbers are even worse there. We have a ways to go from a cardiac perspective. And then for the last 2 things like defibrillators and ventricular assist device therapy, I'll mention those briefly, but we're collecting more information on that, and we'll be hopefully talking about that in the future. And then lastly, from a novel therapy perspective, right, we're hearing all sorts of things about where things are going from a skeletal muscle perspective. How do these affect the heart? Nobody in this room has any idea. That's not an acceptable answer. We need to understand that now, and we need to follow that as we move forward. We can't wait 20 years to figure that out. And so for a quick refresher, for those of you who aren't used to talking about this or haven't seen any of this, here's the general way that things go on an average, for an average boy with Duchenne. Now, nobody's average, but this gives us an idea. So in the beginning, when we look by even things like MRI, we can see that for most boys, especially in the first decade of life, they have normal function and we can't find any evidence of fibrosis, at least from an MRI perspective. And then on average, around 14 or 15, we see the development of fibrosis by cardiac MRI. Function is generally still normal at that point, but there is a slow decline that happens by about 1% to 2% per year. Some boys it's more, some it's less, but on average about 1% to 2% per year. And so by the time they hit age 18 or 20, we see the first signs where their ejection fraction is down. And then the last part is that tends to progress over time. What are the numbers from that perspective? Unfortunately, what I'm going to tell you right now is we don't know. There's a big, gigantic question mark. This despite what we do know from cardiac data, which suggests that cardiac disease is the leading cause of death in Duchenne right now. And we have a big question mark there. That's not good enough. And so how can we go about improving cardiac therapy right now? Really, when it comes to treating cardiomyopathy, there are three pillars of cardiac therapy. First, ACE inhibitors and ARBs. So they work in a couple of different ways. We have good data that shows that they slow the progression of fibrosis in the heart. And then over the long term, especially in later stages of cardiomyopathy, they also relax the blood vessels. So that means that the heart doesn't have to work quite as hard. Two, beta blockers. These are things that slow the heart rate, right? As everybody in this room, I think, knows, most of our boys, almost all, have an elevated heart rate. Beta blockers will take that down, make sure that the heart isn't stimulated quite as much, right? You want your heart rate to go up when you're yelling at your mom, but you don't want it to always be up that high. That's extra stress and strain on the heart, and we can knock that down a little bit. Over the long term, it also helps to treat abnormal rhythms if you develop abnormal rhythms, which we are starting to learn more and more. The majority of our men, as they get into more advanced cardiomyopathy, have a variety of abnormal rhythms. And then lastly, aldosterone antagonists or mineralocorticoid receptor antagonists. These are things like eplerenone and spironolactone, and they also work by slowing fibrosis. And they work by disrupting when the heart and kidneys are kind of working against each other. So they actually start to block some of the hormones released by the kidney that have an adverse effect on the heart. And so when we talk about delivering cardiac, effective and optimal cardiac therapy, most of what we have talked about here and historically is really that first part, initiating cardiac therapy. What we have started to learn in other types of cardiomyopathy and what obviously the neurologists are starting to learn is that's not good enough. You get a lot of bang for your buck just by being on therapy. That's important, but we can do better. We can optimize therapies, and there are ways that we can learn how to do that effectively. And then lastly, we have to monitor for side effects if we're trying to optimize therapy. If we're not staying still, which we don't want to do, we have to monitor for side effects because every single medication that we use has some side effects. And so a lot of what we're starting to learn has come from cardiac MRI. So from the 1940s through the 1970s, the way that we understood the heart in Duchenne was really based on autopsy studies. And what we saw in boys who had passed away from cardiomyopathy is they had evidence of fibrosis. So on screen left, what you see is some heart tissue. The light gray is areas of fibrosis that are kind of extending like little fingers into the dark areas, which are the heart muscle. And that was the only way that we knew things in the very beginning. Then in the early 2000s and especially by the 2010s, we realized that cardiac MRI can actually see this without needing to get heart tissue. And so by using things like LGE, we could detect this area of fibrosis, and we said, now we have the solution, we can target therapies, we can do all of this sort of stuff. Well, it turns out it's not quite so simple as that. So here's a recent heart tissue sample, right? So now we're in color. This is from one of our patients who passed away from heart, and what you see here is the usual cardiomyocytes kind of in the dark pink, and areas of fibrosis are light pink on your screen right, but there's not a lot of that. In fact, what you see these large areas of white stuff, what is that? It turns out that's fat. And when we start to talk about the heart, we can't actually just call it fibrosis. We have to learn from the neurologists, right? We call it, it's fibrofatty. If you look early, it's fibrosis. If you look late, you're losing muscle. There is no therapy that's gonna take that back and reverse that fat back into muscle. And that really is fundamental when we talk about therapies, right? Time is muscle from a heart perspective. We take what we have said from heart attack patients for a long time is muscle. And this tissue shows us the same thing is happening in the heart. We have to initiate therapy. This is also where, when we're talking to the FDA and other stuff, if we wait until the heart muscle is gone, even if we have an effective therapy, it's not going to matter. We've lost too many cardiomyocytes. We have to talk about how we can do this earlier to preserve cardiac muscle so we can make a fundamental difference and change that trajectory over time. And again, if we just would have listened to the neurologists, and that hurts me as a cardiologist to say, we would have had this information from a long time ago, right? So from imaging DMD, this is one of their slides. They can use magnetic resonance imaging spectroscopy, MR spectroscopy, to show that there is fibrofatty changes that happen in the muscle. This is the same thing that happens in the heart. It just happens later. And that is fundamental, and it's why we have to start earlier, why we have to optimize therapy, because we can't wait till the end. Again, you're still going to get bang for your buck by starting these therapies late, but we've missed an opportunity to really improve things over the long term. And so we have to start talking about cardiac therapies from a preventative perspective, as well as later on when we're trying to optimize when boys or men develop heart failure, right? Skeletal muscle therapy, that's all of what we just heard about. Trying to intervene earlier and earlier. We have to talk about that from a cardiac perspective, and we have to change the language. And there is data to suggest this. So I highlight this study because this was published within the last year, and I think it's important for a couple of reasons. One, it showed in boys, this is in France, so 8 different hospitals in France over 17 years, and they looked at the boys who were started on perindopril early, and they followed them over the long term. And what they showed is that the boys who were started on this early had improved long-term survival and less hospitalization for heart failure. Right? That's the data that we're looking for. This is the best way we're going to be able to do it. The other reason why I highlight this is it took 17 years to answer that question. That's not good enough. We have to find ways to get this data in a timely way and change what you're doing right now. And so where are we now? So what does the data support? Or where is consensus when the data is still lacking? So early triple therapy is what I would have told you up until about the last 2 to 3 years. So starting an ACE inhibitor at age 10, or if you have evidence of fibrosis or systolic dysfunction, your heart's not squeezing earlier, then you need to be starting it at that point. You know, we're going to start eventually having a discussion about when to start it even earlier. We're not quite there yet, but that's coming down the pike pretty soon. From a beta blocker perspective, once you have evidence of cardiac dysfunction, you need to start it. That's what all the major guidelines say. Even though the data is not quite there as much as possible, there is consensus on trying to do that. And then lastly, from the aldosterone antagonists, the eplerenone and aldactone, when there's evidence of LGE, we do want to go ahead and start that. Now we're going to talk less about initiation and more about optimizing. This is really an area where we have to learn from non-DMD adult cardiologists, right? This is the paradigm for how they treat patients with cardiomyopathy right now. And we are way behind. And so, and in fact, if you talk to Dr. Barth or from some of the other adult cardiologists, or even from families that have been transitioned from pediatric cardiologists to adult cardiologists, oftentimes when they go there, they start new medications and they just start up titrating, and families go, what the heck has been going on for a long time? We need to get there. And then also, again, learning from neurologists, right? They didn't just stop at, okay, we need to start this therapy and we're not going to try and optimize and figure out how to do stuff. There are multiple trials now trying to figure out how to optimize steroid dose. It's not just start it. They're like, yep, that's old hat. Now we're going to actually try and figure out how to optimize the dose. Turns out the same thing is going on from a cardiac perspective. And really that's from a non-DMD cardiomyopathy perspective. So this is from a recent paper within the last year where they were talking about how we're going to move forward in non-DMD heart failure. And the way that they say that is optimize foundational therapies, right? Take those pillars of cardiomyopathy and not just initiate them, but optimize them. And we have to start using the term guideline-directed medical therapy, or GDMT. That is getting on the right medications at the right time, but also getting on the right dose. That has to be part of how we talk about cardiac therapy now. It's what happens in dilated cardiomyopathy outside of Duchenne, and we have even more reason to probably start that earlier. They also talk about quadruple therapy here. And you're thinking to yourself, oh my God, he didn't even remember his slides. He only talked to us about 3 things. We need to actually talk about what to do right now. And that's why I said that triple therapy was what I would have said 2 years ago. Now we're in a whole different place. There are 2 classes of medications that we have to be talking about. And I think there are murmurings throughout the community with it. Those are ARNIs. So angiotensin receptor blocker neprilysin inhibitor. So it's like that ARB, but it has an additional medication on top, and what we call SGLT2 inhibitors. Don't worry too much about it, but you'll see it abbreviated as SGLT2Is, and I'll talk to you a little bit more about that. And again, they focus not just on initiating therapy, but how we are going to optimize it. So, from that perspective, so we have 4 things to remember. So, right, so GDMT, right? Initiate and optimize dose. Don't stand still, right? Your boys change over time. You have to optimize the dose to keep up with them. We'll talk a little bit more about ARNI and SGLT2. And so this matters so much in non-DMD dilated cardiomyopathy. They're doing clinical trials about how to initiate and uptitrate medications. Again, it's just like in neurology. They're not talking about how to start it. They're talking about how can I get people on these therapies that we know make a difference, and how can I do that in a timely way? And we need to get there. So what is Entresto? So as I said, here's both the trade name and the generic name. So sacubitril valsartan. And a couple of years ago, this was a fundamental change for non-DMD dilated cardiomyopathy. And it's one of the first things in a number of years that had actually shown to make a difference on top of that usual triple therapy. Valsartan, I won't even talk about because I think that's well known to the community. But this additional medication, the neprilysin inhibitor, works by affecting one of the enzymes that breaks down a number of molecules in the blood that affect how the heart and kidney kind of talk to each other. And so this really has become the standard of care in adults, and the only reason usually why it's not in some people is from an insurance perspective. And so the big issue with it, and why I don't have every single one of my patients on it, is blood pressure. And this is a situation where us learning together and speaking to adults makes a big difference, right? How can we try and figure out who to start it on and how we can optimize, and we're working on that. So the biggest reason why I don't have all of my patients who have an ejection fraction less than 40% on this is that neprilysin inhibitor, it affects your blood pressure. Most of the boys, actually they're not boys, most of the men that I see who are in their 20s and 30s, their blood pressure on a good day is a systolic, a top number of in the 90s, low 90s. And the problem is trying to get the Entresto on board, sometimes we lower that too much to the point where they can feel symptoms. And that's a big deal, right? Because all of these therapies are not just focused on trying to improve what your MRI looks like, it's trying to improve how you feel day to day. And that becomes an issue. So we're trying to work on how to optimize that dosing, especially in our older men, so that because I do think this is going to make a difference, especially late on, but we have to figure out how to do that efficiently and effectively, and that's going to require some work. The other class of medications, the SGLT2 inhibitors, the generic name for those is dapagliflozin and empagliflozin. That's hard for even me to say, so don't worry about that. But the SGLT2 inhibitors, this is a story of serendipity. These were developed actually for diabetes. And the way that they work is they cause you to pee out sodium and glucose. So if you have a blood sugar that's too high, this sounds like a great medication, right? We're going to fix things by just making it go out instead of staying in. And what they found out incidentally is it turns out it makes a difference on heart failure outcomes. So in the beginning they said, well, yeah, that's all good. We weren't looking for that, so we didn't focus on it, but maybe we'll go looking from a heart failure perspective. There have now been multiple clinical trials in adults with an ejection fraction less than 40% that this fundamentally changes and outcomes. And that's even in people who are otherwise optimized on their other therapies. And so This seems like a no-brainer, especially from my perspective, because most of my 93% of the patients that I see in Cincinnati are on steroids, may be on metformin, have some glucose problems. This seems like a no-brainer, right? I'm going to definitely add this on. Well, it turns out this is a situation where we have to talk about how DMD might be different, right? So for most of the men that I take care of, going to the bathroom is a big deal, right? Maintaining that independence is such a fundamental part of their quality of life. And oftentimes I'll even see them, they don't even want to drink because they know if I have to go to the bathroom, that's a big deal for my caregiver, for me. And these medications, unfortunately, one of the ways that they work is by making you pee more. And that can be a big deal. So as we're starting to learn from this, what I've learned is some of the men, they don't want it. Right? It may make a difference over the long term from a heart failure perspective, but for their quality of life, they don't want it. So we have a very frank conversation. Here's what it might look like. Here's how it's going to affect your life day to day and for your family around you. Do you want that? And let's be upfront, because I don't want to prescribe it and have you take it intermittently. That's not going to work well, because then I don't know what the side effects are or the benefit of some of these things. And the other component of this is there are some risks from these medications, right? Anything that makes you urinate glucose can be a potentially big deal, because if you have an accident and you have more sugar in an area that's warm and wet, that can predispose you to infections. And again, for the men that I take care of, groin infections can be an issue no matter what. And this is a situation where we say, hey, we can learn from other people, but only so much. There are things that are important and singularly different about Duchenne-related cardiomyopathy, and sometimes it's just simple things like, functionally, how am I going to do these things and maintain my independence? So now, from this perspective, it's less about blood pressure and more about some of the other things that is causing me to talk to people as a cardiologist about things that I've never talked about, which is, how often do you go to the bathroom? How do you go about doing that? Here's how that might change. And so we'll talk a little bit more about device therapies hopefully next year. And this goes towards what I think the funding for PPMD makes a huge difference, right? To be able to understand some of these things, we need to pull together groups from all over the country to be able to understand that. We've started that from a ventricular assist device perspective. We're working on our first publication there. But the other thing that we've seen is this. So this is the number of ventricular assist devices in patients with all muscular dystrophy. This is about 70 to 80% dystrophinopathy. But what we saw is early on, there was only 1 or 2 centers that was doing that, right? And then as we started to share data and say, this can be done effectively in some men with Duchenne and can easily, well, I won't say easily, can be done more commonly in patients with Becker's, other centers said, all right, maybe that is an option that we're going to do. Whereas before, there was not really much of anything. And so that data that we're presenting right now for publication, it's already old. It turns out when you look at these numbers now, the only reason why 2020 down is a little bit of a virus came along and changed things. But when you look now, we have almost twice as many VADs that have been implanted in patients, and the majority of those are in people with dystrophinopathy. So this is where sharing that data makes a difference, and it can make a difference in a very short period of time. And so hopefully next year, we'll be talking about some more granular data in that regard. And then finally, to get back on my soapbox, so how do any of these things that you guys just heard about have any impact on the heart? We have no idea. And there's right now no plan to follow over the long term. We're going to do better with that, and we may be one of the solutions to that, but we're going to have to work together with industry to be able to track these so that we're not waiting 17 more years to figure out the answer to that. And the way that we're going to do that is through ACTION, which is 58 centers kind of working together from a pediatric perspective to improve heart failure in children and young adults. And as you heard from Pat, PPMD has done an amazing job at funding our initial efforts, and we're going to scale that up pretty significantly to look at all dystrophinopathies at this point, so trying to get more data on carriers and Becker, and engage some of the adult providers too as well, so that we can have really a larger cohort. This is important for improving what we do right now, to answering some of those questions that we have, and also so that we can go to the FDA or industry and say, here's what the natural history looks like right now. Now let's design a trial together. Because right now, everyone says, we have no idea. We can't design a trial, or we won't design a trial. We need to come to them with that data, and then we can hold them their feet to the fire a little bit more and say, okay, now you're gonna have to give me another reason why we can't do this. Because right now we're giving them an easy excuse. So, thank you.
Does anyone have questions for Chet? I can tell you a story about Chet. You ready? So I have a friend who I've known who has a young man with Becker. His name is Billy. And he, before COVID, decided that he would move out to Seattle with his friends and live with them. And then the pandemic occurred, and he had a job in Seattle, but then he didn't have a job in Seattle because of COVID. And then he was very lethargic. He was spending a lot of time in bed, and he was gaining a lot of weight. And his mom was calling us and saying, he's gaining a lot of weight. I think it's because he's overeating. And we sort of did this circle, and he said, I think he's in heart failure because I know him. And so they brought him in, and you put a VAD in him. Mm-hmm. And last time I checked, he's out in Palm Beach playing around in the pool. Not exactly in the pool, but out in Palm Beach. So he's doing very well and healthy, and I think that we might not have had Billy if not for you.
And I think the other thing that's important about that is that we gave them an avenue to pursue something that wasn't being offered elsewhere, right? This happens a little bit from a Becker perspective, but from a Duchenne perspective, the early VADs, right? Because let's be blunt, we were the center that was putting those in early on. The way that people found this was through this community. It wasn't because their cardiologists were referring, right? A number of them had actually been told there's nothing more that we can do. This is it. And I'll use the example of one of our patients, Ricky, who came in that situation, and 4 years later, he's been admitted once to the hospital, right? He's had a ventricular assist device for 4 years. He sends me pictures of him going to all sorts of Star Wars stuff, right? One of Mom's biggest complaints now is he has way more energy, so then he curses at his video games too much and loud, so then I have to lecture him about that. And she's like, tell him the VAD won't work. And I was like, well, that's not true. You know, he can do those sorts of things. But that story still gets me fired up, right? He had to come through the community to know that we had even access to this option, and that's not okay. That's not good enough. And one of the families, for a different type of muscular dystrophy, actually went and called afterwards because we told him he had an option. He didn't believe me. He was like, no, this man is crazy. I don't know what he's talking about. No one else has told us this. And then he actually called some of our other patients and said, is he nuts? And they said, well, he is a little bit nuts, but he's right. And he got an option where one didn't exist. Not everyone needs a VAD or should have a VAD, but we should be able to talk about it. So that we can, one, figure it out, and some of those people should get a VAD. So.
Thank you. Thank you very much.
Oh, yep, Linda.
Is there a question? I mean, is this on? Yes. It is not, okay. You know, one of the things, thank you, Chet, that was outstanding. And transplant is also an issue like VADs, where I think that transplant hasn't been available to this community in any significant way previously. You know, way back when there was a patient at Cincinnati Children's who got transplanted who was a Duchenne, but in order to get him listed, we sort of said he was a severe Becker. And interestingly, that young man, it's probably been 15 years now. He's still alive and well. And so do you have a thought about the impact of immunosuppressive medications on the skeletal muscle disease? You know, he was non-ambulatory at the time we transplanted him, and interestingly, he became ambulatory again. Now, maybe that was related to his heart failure, and, you know, he just actually, with improved cardiac function, became ambulatory again. But he was ambulatory for quite a while after transplant.
Well, and I think obviously from a steroid perspective and for some of the new novel anti-inflammatories, that's why people are trying those therapies. So one, could it make a difference? Yes is the answer to that. Do I think we have a way to go as somebody who is a heart transplant doctor? Absolutely. And in fact, to tell you how far we have to go, when we presented Ricky's case, and again, I can use it because he says it's okay and he's all over videos and stuff, you know, one of the cardiologists at our institution came up to me afterwards and said, "What are we doing?" And I got all fired up because I can get fired up. But that's at a center that's doing this, that has shown we can do it, that we have outcomes for, and all they see is a diagnosis or a wheelchair. And they shut off their ears before even hearing the information. It's not going to be right for everyone, full stop. But there's not a single thing that's right for everyone in any disease. We have to start understanding who does well with it, who does not, and then also factoring in if we don't know what the family or the man or teenager wants. There are times where we just have to say we don't know. Here's when we think this is a really not a good idea, and I think we're starting to understand that, but everything else in between, we say, okay, here are the risks, here's what we know so far, and let's make a decision together.
Thank you.
Thank you, Chet.
Yep.
And that young transplant, the man who was transplanted at Cincinnati Children's is now 29 years old. He walked until he was 23, and his heart's still pumping. So thank you.